Hey there, this is Dr. Aaron Kowaleski. I'm here to talk to you about chronic DVT and the treatment options. If you have chronic DVT, you probably have leg pain, swelling, maybe even some skin discoloration, and in some cases, you may even have open wounds that have been taking forever to heal or haven't been healing at all. So who gets chronic DVT or chronic deep vein thrombosis? The easy answer is anyone that gets acute DVT or new onset deep vein thrombosis. Well, who gets that? So it's pretty evenly distributed among men and women. Some patients have genetic clotting disorders, which make them more likely to develop clots in their legs or elsewhere. You have post-operative patients where DVT is very common, especially with orthopedic surgery. You can develop clots in your legs after those procedures as well. You have patients that have gone through traveling for long periods of time, where they've been on a plane for several hours, or in a bus, or in a car, or in a truck, and their legs get swollen and red and very painful. Anyone that's been diagnosed with a clot, that can develop into chronic DVT or long-standing DVT. A little bit of understanding about acute and chronic and what the difference is. In medicine, we have acute, subacute, and chronic for every condition. So acute means something that occurred within 2 weeks. So if you fell and broke your ankle a week ago, then that's still an acute ankle fracture. Or if you develop a clot, that is acute in the first 2 weeks. That's important because clot in that early phase is more of this gel-like substance, almost like jelly. It even looks like jelly. And then subacute is going to be 2 to 4 weeks, which is this kind of middle phase where it's not quite that jelly anymore, but it's not going to be chronic DVT. And then after 4 weeks, you have chronic DVT, or any condition would be chronic after 4 weeks. To understand what DVT is, let's go over a little bit of anatomy just so you have a better understanding. So DVT, the first 2 words are pretty important: deep vein. We have deep veins and superficial or shallow veins. The superficial veins or the shallow veins are the ones that we can see with our naked eyes, where you can see a varicose vein, that's a superficial vein. Or you can see those spider veins on your skin, that's a superficial vein. Deep veins are in the muscles, so they're going to be deep. You can't see them with your eyes, but you can see them on things like ultrasound or CAT scans. So those deep veins, they tend to be bigger. They're draining a lot of blood out of the muscles in your legs and arms, etc., to carry that blood flow back to the heart. Which brings me to my next point. Veins carry blood flow from toes back to heart, fingers back to heart, brain back to heart. Arteries go the opposite direction. We're not talking about arteries in this video. We're just talking about the veins. So deep vein thrombosis means you're getting a thrombus or a clot in the legs. The concern of DVT is that clot can move up to the lungs. That's why we treat it. Once you develop a DVT, that invokes an inflammatory response from your body. That clot blocks off the blood flow out of your leg or wherever the clot is, and so your body needs to open that up to restore flow through it. In some cases, with the help of things like blood thinners, it can open up that vein in its entirety and get rid of all of that clot with no further issues. In some cases, the inflammatory response is so much that it can actually damage the vein itself. So even though our inflammatory response is trying to help us, sometimes it can overreact and do more damage than good. In that case, what it does is it actually scars the vein down. So I don't like the name chronic DVT because there is no deep vein thrombosis in the chronic phase. It's actually chronic scarring of the deep veins. Yet we stick with this DVT phrase because it is a complication of having a DVT in the first place. But in reality, if you look at it underneath the microscope, there's no clot there. It's just scar tissue in the vein that's really shrunk the vein down so it can't push that blood through. So it still acts like a blockage, but it's just a scar tissue wall that won't let the blood through. Workup for this condition and potential treatments, pretty easy. It's usually just an ultrasound of the affected area, and the affected area is most commonly the legs. So non-invasive study, easy to do. We do it here at ECCO Medical. Easy to diagnose, and then we also do the treatments here. There may be additional imaging, such as a CAT scan. Not all ultrasounds can see up into the pelvis or the abdomen. chronic DVT or even acute DVT can move up into the pelvis and abdomen. And in some cases, we're gonna wanna make certain that the pelvis and abdomen are unaffected. The deep veins in the pelvis and abdomen are unaffected before we offer any kind of treatment. As far as treatment options for chronic DVT, there really aren't that many. And to be honest, most doctors out in the community don't really know what to do with chronic DVT. So make certain you educate yourself on your condition and make certain you get to the right place. So first and foremost, you can do nothing. That's not really a treatment option, but some people opt to do nothing and just live with their discomfort. Secondly, you can be on blood thinners. Most people that have chronic DVT, if they're not seeking definitive treatment, they're on blood thinners the rest of their lives, unless they learn about or find a place that offers treatment for chronic DVT, which isn't really a lot, which is unfortunate. The last thing is actually doing what's called chronic DVT recanalization, which is where you go in and you open up the veins to restore flow through the veins. And you can even get off your blood thinners permanently if you get this procedure done. So what is the procedure that opens up the veins in your leg? It is a procedure that we do here in the office. You don't have to do it at a hospital. You don't need general anesthesia for it. We use moderate sedation, which is just light medications that let you snooze or sleep through the procedure. You walk in, you walk out of the office, and you have a very relatively easy recovery. We do a single needle stick and we go through the ankle. So we usually go through behind the ankle. There's a vein back there that you can get into, and you thread a wire through that needle into the vein. We're using ultrasound guidance to get the needle into the vein in the first place, and then X-ray guidance to guide that wire through the needle and into the vein itself. Once we navigate that wire through the scar tissue in that vein, then we can thread balloons over that wire into the affected areas of the vein and balloon it open. What this does is it causes the scar tissue to snap open and then remolds the vein to a normal shape and allows blood flow to get through it again. Sometimes we'll need to place stents, especially if we find out that you have something further up in your pelvis, like an impingement syndrome, like May-Thurner syndrome, that caused your clot in the first place. The procedure itself usually takes 2 to 3 hours, depending on the extent of the scar tissue in the vein. We would be able to do that typically in one procedure where we evaluate the leg, treat the leg, open up the veins in the leg, and then also open up the veins in the pelvis afterwards. As far as success rates for this procedure, there's about a 90% success rate on procedure day of getting these veins open and restoring flow through. There's not a lot of research studies out there about chronic DVT and success rates, especially when comparing it to other countries or other hospitals or other clinics, et cetera, et cetera. But by and large, we have about a 90% success rate with long-term patency or long-term openness of these veins after treatment. So for this procedure, we would be changing up your medications a little bit. If you have chronic DVT, you've probably taken Lovenox before, which is the injections that they do in your belly. And I know it's uncomfortable and not exactly pleasant, but for this procedure to be successful, this is the best protocol. So what we do is we do Lovenox for 30 days, starting the day before the procedure. So before you're actually doing the procedure, you should have 3 doses of Lovenox on board. This is pretty important. A lot of patients forget this, and then we're not able to do the procedure if they show up without these doses on board. So please remember that if you do opt to get this treatment, please, please, please remember to do your Lovenox injections. So you start the day before, you do your morning and your evening dose, and then you do a dose the morning of your procedure. So we have those 3 doses on board. That provides an adequate amount of blood thinning so that when we do go in and balloon during this procedure, it doesn't cause new clots to form. That's the importance of having this blood thinner on board. So that way, during the procedure, we don't get new clots to form. After the procedure, you continue the Lovenox for 30 days total, and then you convert to an oral blood thinner like Eliquis or Xarelto. We can also use some things like Plavix. They aren't quite as effective, but not all prescription plans cover Xarelto or Eliquis. We can sometimes help out with that with pharmacy plans. So we would convert you typically to Eliquis. You would do that for 2 months after your Lovenox. So the protocol is 1 month of Lovenox after the procedure, 2 months of Eliquis, and then we do an ultrasound. And then at that point, we determine whether or not you need any more blood thinners. At that point, if we say that you don't need any more because everything looks good, we convert you to aspirin 81 milligrams or a baby aspirin for a year. After the procedure, we're gonna have you wear thigh-high compression hose for a week. If you have bigger legs, maybe due to swelling or just you're a bigger person overall, then we can do wraps on the thigh and calf. After that week, we'll have you convert just to knee-high compression for the remainder of your follow-up time here at the clinic. You really shouldn't expect to see results for at least 3 to 4 weeks after the procedure. You'll be wearing compression that whole time, and we don't want you to come off that compression because it really helps push blood through that treated vein, allowing it to remodel appropriately and really restore that flow through it. So compression is very important. And like I said, results do take about a month to start seeing them. Other things to expect, just like every single medical procedure known to man, you're gonna have some soreness in the leg where we ballooned and treated you. We're stretching that vein, we're stretching the muscle around it a little bit. You're gonna have some soreness for about a month afterwards. It's not gonna be intense, it's not going to be a 10 out of 10 pain, but it's gonna be 3 to 4, and you may even have some bruising, but that's because you are on blood thinners. After you get this procedure, you're gonna be coming to our clinic for quite a while, but not too often. So once we do this procedure, you'll be coming back to the clinic 1 month afterwards. You'll be getting an ultrasound of the veins that we treated, and then you'll also have a clinic visit. We'll just be looking to make certain that you're improving. You shouldn't have all of your improvement yet from this procedure. That can take a few months, but we're just wanting to make certain that what we treated is open. We won't be making any clinical decisions, but the importance of that first appointment is we are going to be switching you off of the Lovenox to an oral blood thinner like Eliquis or Xarelto. After that one, 2 months after your 1 month follow-up will be your 3 month follow-up. So at that point, the ultrasound should really start looking better. Your symptoms should have significantly improved at this point, and your quality of life should really be heading in the right direction. At that point, that's when we'll look to see if there is a need for any form of reintervention. Remember, about 90% of these procedures are wide open at 3 months, but there's that 10% that aren't. So if you treat 100 patients a year doing this, then 10 patients a year need to have another procedure after the first one. That 3 month visit is when we'll determine whether or not, 1, you need to continue blood thinners, 2, whether or not we need to do another intervention. That ultrasound will give us a lot of information. After that 3 months, if everything looks good, then it goes to 6 months after that, and then it's just annually, once a year, show up, we just make certain that the veins look good and they're working normally. If you do need a reintervention, then that would start that whole protocol over again, meaning you do the Lovenox again for 30 days, you'd follow up at 1 month, we'd switch you to the oral blood thinner, and et cetera, et cetera, et cetera. So if you need reintervention, it just starts that whole circuit over again. But if everything looks great at that 1 and 3 month ultrasound and that visit, then your visits start being spaced out more and more. The minimally invasive procedures we do at ECCO Medical are outpatient. You walk in, you walk out, and they're very low impact on your body. We use moderate sedation for the procedure, so you're snoozing or completely asleep throughout the procedure, but we're not putting a tube down into your lungs to breathe for you like you need to do with general anesthesia. In general, people don't remember the procedure. They may remember a flash here and there, but for the most part, you don't remember anything about it. It's safe. We do it here every single day, and we have skilled and trained staff to be able to administer these medications safely. If you have any questions that weren't answered while you were watching this video, or if you think of anything afterwards, please don't hesitate to ask me or one of the providers that you speak with. We're always going to be available, and you can always call us if you forget to ask us something during your consultation.